So I'm Jean-Pierre Sallet, and I'm the project director there for a USA-funded project called, it has a very long name, it's called Global Health Supply Chain Technical Assistance Francophone Task Order. So I'll start basically, I'm going to talk about that program, so I will skip this one for the sake of time, and that's the outline basically I'll be using. All right, so why did we have to do a program like this? There was an assessment that was conducted in 2015 of the supply chain in Benin, and that was conducted with the technical assistance of the SciAps program in collaboration with USAID and the Beninese Ministry of Health. That was an opportunity to obviously do an assessment and identify the key weaknesses of the supply chain, which are highlighted there. So one of the issues was the fact that the management of the supply chain, particularly as you go down the supply chain, is very often managed by people that are not qualified or didn't get the adequate training for supply chain management, lack of resources, poor availability of essential medicine and other related commodity, particularly at the service delivery point, and also the lack of coordination amongst stakeholders. So nothing really, new when you compare Benin to other countries. So how did we implement that system? So basically, one of the ideas was to have, first of all, a partner to implement the program. And so we identify what is called the Platform du Secteur Sanitaire Privé, which is a foundation for the private health sector in Benin. So we had, as a project, an MOU with that organization. And then what happened in the agreement, it was stipulated that the pharmaceutical directorate called the DPMED of the Ministry of Health will be the main recipient of the program. The PSSP will receive the fund allocated for the implementation of the YLPP that is being channeled through us, and our project will provide technical assistance to monitor, to support the program itself and also monitor its implementation. So the way it works, we did it in two phases. A first group of 15 young logistician professionals, we call them YLP, were recruited in November 2018, and then we had a second batch of 15 as well in 2019. So the way it works, once people are recruited, they went through a 2-week orientation, and then after we assist them with what we call an installation tour, if you want, to introduce them to the commune where they're supposed to be placed. And also in March 2019, we conducted a baseline study to make sure that we had baseline data to be able to see progress or how the supply chain benefit for this intervention. So now, on top of it, so as you can see on the right, you have the map of Benin. On top of it, to provide support, we recruited a coordinator, a statistician, and an accountant that were placed at the PSSP. And us as a project, we do have people, technical staff that are based in Cotonou in the south, and Parakou and Atitengo, which are the main two of the city of Benin in the north. In addition, we receive support for motorbikes, laptop, and internet connection from other partners like UNFPA and UNICEF. because the budget for USAID covered only the salary and the operational cost, but not those equipment. And furthermore, we developed also a set of indicators to be able to monitor the performance of the program, but also the performance of the YLP themselves. So this is just a list of indicators that we've been using to monitor the implementation of the program, and you can see the frequency of the data collection. So I'm not going through it in detail, but as you can see, the monthly indicators are the ones that are actually assisting in managing on a monthly basis progress of the program. Here, just a picture of, I was talking about the installation tour, so I give you an idea of what happened at the community level when we went to discuss with local mayors, local government officials, present the program and get the buy-in, and present the YLPs and try to be clear about what are the expectations from both parties. Okay, so what the role of the YLPs? So this is a list of the tasks that they're supposed to support. Again, I won't go in detail through that, but basically what is important to understand is that they are based at the communal level and they're working with what they call within the health zone, which is more or less the equivalent of a district if you compare to other countries, and working with the Ministry of Health staff and the local government staff. And on the right, you can see how the coverage. So the blue stars are where we place the YLP in 2019, and the yellow star are the one in 2020. Okay, but basically one of the tasks is really to educate local government on the fact that if you have no product, you have no program. Something that we all know, but I think it's needed to hear it regularly. Okay, so these are some of the activities that they've conducted in support of the program. So they've been doing continuous coaching of health facility staff. They're assisted with data analysis and preparation of orders, requisition. They support what they call self-post in the development and submission of reports. In some cases, for example, in the north, where you have the rainy season and access to this health zone could be difficult, they would ensure that the health facility have 5 months worth of stock. They support periodic inventory. What I think is important is that they make sure that local government understand the importance of the supply chain and don't just assume because there's a health center that in their commune that it is all good and product will be there. So I think they've been doing quite a lot of work in conducting advocacy on the importance of the supply chain. Also, there have been other activity. For example, they would recommend purchase of storage equipment and other. For example, in one of the commune, they recommend the procurement of solar panels. So to ensure regular supplies, of electricity for the cold chain, for example. Another thing, as I mentioned, and that was one of the challenge, which happened at both national and at the commune level, is the coordination with all stakeholders. And so they've been actively involved in making sure that whatever they do is done in coordination with all the different players. So that's just an idea of what happened to the pharmacy after the YLP put them in order. These are two of the YLPs. So it's a mix actually of men and women, which is important. And I must say that during the second batch, we make sure that we had, tried to have this gender balance in the team, which I think we succeeded. So you can see two of those ladies that are actively working in some of the warehouse or the health zone warehouse. Yeah. Here I'm going to share with you some of the results For example, one of the indicators, sorry, is the percentage of trace product that are stored according to agreed minimum and maximum stock level. So you can see that for particular health zone, some improvement. Of course, it is very difficult sometimes to achieve 100% with this indicator because there's so many parameters. For example, the health zone could be limited in terms of budget that they have to make sure that they can reach the maximum parameters. However, it doesn't mean that they were out of stock because, as I say, it's really an idea of where the stock are between the min and the max. Okay, the one next to it is an interesting one and a striking one in terms of result. It shows, for example, for the zone of Cotonou 1 and Cotonou 4, how the reporting rate have gone actually from 0 to 100% in a fairly short period of time. I think that was one of the things that was striking with the program is the fact that very quickly they've been able to be part of the team and produce results. Okay, so these are again another indicator. It showed the percentage of health facilities that submitted the report over the last 3 months. So as you can see, for example, look at Cotonou 1 and 4, you can see the difference between the private and public sector and the data of a particular health zone over the average national data. So as you can see again, for the public sector, 100% was achieved. And they're working also, they're getting involved more and more with the private sector, but initially you can see that that the private sector was behind. Okay. All right. So this one is again, the product that are stored according to agreed min and max parameters. And then here to the right, you can see the percentage of tracer products out of stock. And you can see there's been some improvement. For example, particularly in orange, these are the family planning items. You can see that it went from close to 90% to almost 20% stock out. So these are improvements. Okay, and the last another slide. This is very interesting because it shows those two slides those two graphs are related. Because on one hand, for the same zone, for the same period, you can see how the stock out rate have decreased while the consumption has increased. So we like to think there's a direct relationship between two. If products are available on a regular basis, the consumption is expected to increase, and so the service delivery. Okay. Here, these are just some testimonies that we got from the people, the counterpart that the YLPP are working with. Okay, for example, one of them said first time that we have 100% reporting rate by a facility. We had quite a lot of testimony like that. There was one that was interesting that we got to know. Our financing is essentially initially for family planning and malaria product. However, they're working in an integrated manner in the sense that they're supporting the supply chain for all products. And one of the health zones in the north say that since they have the YLPP, they haven't had any more death due to snake bite, because in the north there are people working in the field, cotton fields, and they were very often out of stock of snake bites serum. So that was very encouraging. So this is we had a workshop, a national workshop to share the progress, and that was a great opportunity to actually hear what the the YLP had to say about the integration, the work they've done, but also the counterpart were there to provide testimony. As I say, those logisticians are involved in assisting with stock management in their commune, but we've been also involving them in other activities. For example, the distribution, national distribution of bed nets, or the seasonal malaria chemo prevention campaign. They've been assisting us also with what we call the UV for malaria product. And lately, they've been quite active in supporting the government response to the COVID. As you can see on the right, some of them were on the tarmac very early in the morning to receive product donation that were given to the Beninese government to respond to COVID. And on the left, you have one of the logisticians, which is actually promoting preventive measures to the health staff in the community. All right. Now, the coverage, as I mentioned before, we had 30, actually Benin needed at least 77. Now, the plan is that there's the project from World Bank, and you can see all the red star. What is expected is that by the, well, I would say early 21, that each commune will have at least one logistician. So the whole country is expected to be covered. And now let's finish. So of course, you know, there's been some challenges. For example, I did mention that we had motorcycle, laptop, internet connection, but not enough. So we're trying to get that from the donor. Now the key question is for the program is that how sustainable is it going to be once the most support is over? So we're working on that now. And then what is important just for sustainability's sake, again, is to make sure that this position exists in the establishment. That will also support the institutionalization of the YLP. So my word is, we like to think that it is a good model that supports delivery of health services through the use of youth and collaboration with all stakeholders. I'll stop there. Thank you.
Hi everyone, my name is Zoya Mohamed. I work as a supply chain analyst for InSupply Health Limited, and today I will be presenting on building data use capacity of health workers using virtual learning packages for a more responsive and resilient supply chain during COVID-19. So just a little bit about InSupply Health Limited. We are not your typical health advisory firm. We are a startup fashioned more like a social enterprise, and our teams are entirely local and have a deep understanding of the context we work in and hold strong relationships with the communities we work with. But we have a regional and global outlook as well, which allows us to partner with communities and introduce innovations that are adapted to their needs that is sustainable. InSupply Health is an affiliate of JSI Research and Training Institute, and we are based in East Africa. Our mission is to transform lives by co-creating innovative and sustainable solutions for healthy communities. Globally, healthcare workers are overburdened, which COVID-19 has compounded, and therefore professional development has been put on the back burner. Yet we know that what is critical is for healthcare workers to be able to use data effectively to build a resilient and responsive supply chain. In addition, the skills and competencies required for establishing a data use culture for evidence-based decision-making is still not well understood, and the digital capacity building tools in existence fall short through their inflexible and time-consuming processes that the schedules of healthcare workers cannot accommodate. In response, InSupply has developed learning packages as a way for self-directed and self-motivated learning for healthcare workers, which are easy to use and user-focused and are effective that can fit into their busy schedules. The packages equip the healthcare workers with the competencies, the skills, and the knowledge required for strong data review teams, and is centered around 7 key personas, which I will discuss in a bit. Essentially, the learning packages aim to institutionalize what we call the innovate, do, review approach and continuous improvement culture that InSupply upholds and implements for every project and intervention. So a bit more about the learning packages. They are online-based modular courses that are hosted on an impact team portal, which is basically an online site designed by InSupply. As mentioned before, they are self-directed and can be accessed at any time and place, and the healthcare workers can sort of navigate through the learning packages at their own pace. They are accessible on a phone, computer, tablet, or any other internet-enabled device. The audience for the learning packages is ideally for data review teams, which InSupply Health has coined as impact teams. But in general, they are targeted for supply chain teams, commodity management teams, and teams that essentially make decisions around commodity security. The main aim of the learning packages is to build capacity around key skills, knowledge areas, and competencies, with the ultimate goal to strengthen the health supply chains and allow for data use teams to perform their tasks optimally by using data for problem solving, action planning, and decision making. A bit around the methodology. So InSupply used a human-centered design focused approach where we worked with the data review or impact teams themselves to reflect around some of the skills required and to come up with the 7 personas. So basically identifying the competencies and the behaviors needed for each persona. We then translated these into a self-assessment to be used by the teams to identify the gaps in learning, but more importantly, to identify opportunities for growth and capacity building. At the moment, we have designed and developed the learning packages, and we really ensured that they should be user-friendly, easily accessible, hosted on an interactive platform, and really draw on self-learning and motivating techniques, which are complemented by relevant examples and decision support tools that they can use in their field of work. We are now at the point where we are completing the beta tests of the learning packages to incorporate the reviews by field experts and the impact teams. We're also incorporating the element of certification. We know really well that one of the factors for adult learning is the whole idea of incentivization. So we're including innovative techniques, including gaming, to cater for the self-motivation and incentivization aspect. So as I mentioned earlier, the learning packages are built upon 7 key personas, which we co-identified with the impact teams. The 7 personas basically are a way to identify the ideal composition for a data review team. So each persona has a set of technical and behavioral skills that they should possess in order to perform their role. The 7 personas that we came up with are categorized into 2, core members and enabling support members. The core members that you see on the screen are really those that operationalize the data use approach into day-to-day tasks. So they must attend all the data review meetings that they have at their respective levels to be able to perform their tasks optimally. And the learning packages help build the skills required for each persona. So just going through the core members, the package for organizing auto centers around key skills and behaviors that they need to perform their role, including role delegation, minute taking, agenda development, and other tools and processes that they require. Key to his or her role with regard to Peter Problem Solver, which the learning course builds upon, is prioritizing problems, conducting root cause analysis, brainstorming solutions, really processes and approaches that a Peter Problem Solver should know and needs to know. After completing the Data with Diana course, one will have learned how to calculate, interpret, visualize, and analyze supply chain indicators to convey what the data is saying to non-data people. So really telling a story using data, and to be able to understand the repercussions of poor data quality on the supply chain outcomes. For supply chain SAM, as the name implies, the learning package focuses on building skills around the logistics cycle, general supply chain processes, measuring performance of the supply chain, and really diving deeper into the supply chain problems and challenges, and critically thinking about the solutions. For enabling support personas, these roles may be held at higher levels of the health system for the sustainability and integration of data use approaches in existing structures and mechanisms. So the enabling support personas include influencing Irene, who really, his or her role primarily centers around relationship building with key decision makers. Resource Rita is all about resource mobilization. He or she knows what resources are available for various activities and line items. They know how to advocate for it and really present it in a way for approval. Lucy Leader, every team, whether data review or not, requires a leader or a visionary. And so Lucy Leader really holds authority, and they're the ones who endorse the intervention. So the way In Supply Health hopes to disseminate learnings for these personas will take a slightly different approach to the core members. While still in development, we are co-creating these packages to include interactive context-based modalities, including webinars, peer-to-peer learning sessions for sharing of best practices, and workshops focused on real-life use cases around advocacy, resource mobilization, and change management. So I'm just going to quickly take you through a quick demo of the learning packages. So In Supply Health will provide to any interested members, data review teams, or impact teams credentials to log in and the URL for the logging in. And you will be brought to a landing page at the top of which there's several tabs, and you just select the Learning Packages tab. And you'll see that there are various packages, so just select the one that you're interested in. So for the purpose of this demonstration, we can go through Supply Chain SAM. So for each course, as I mentioned, they're modular. So they're divided into modules based on the skills and competencies that each persona is required to know. So for Supply Chain SAM, we have the Logistics Cycle module. We have the Data for Supply Chain Management module. We have Supply Chain Performance Management, and we have the Identifying Risks and Taking Action. And each module consists of interactive activities and knowledge checks, which are basically quizzes or interactive activities to gauge how much we know about the topic or content that is being presented. As well, for each course, there are resources that are referenced, which are really tools to help each persona perform their role. So for example, for Supply Chain SAM, the playbook, the impacting playbook, and the scorecard template is referenced. In addition, there are additional resources, including the Supply Chain Manager's Handbook, designed and developed by JSI, as well as a game in which you can test your knowledge abilities through a really fun and interactive way. Again, taking into consideration the whole incentivization aspect, in addition to the certification. So a bit about the results. For each assessment, sub-counties rated themselves on both a competency rating, so a technical rating, and an availability rating. and 88% of the data use impact teams completed the assessment. The assessment really reveals whether one or more members of the team have the skills and competencies required to play each role, or that they need to increase their capacity, as well as if they are, available to the teams when they are needed. So some of the results, while some teams rated themselves highly in certain role profiles, there was a general trend across all the teams, which really helped us identify areas to focus on in the development of the learning packages. So overall, Data Wiz Diana and Organizing Otto were the role profiles that had the highest ratings, whereas Resource Rita had the lowest rating. Mainly the reason being contextual, partly because most of the roles around networking, budgeting, planning, and prioritization are largely done at the higher levels and at the county, rather than at the sub-county where the assessment was administered. The second lowest rating was for Peter Problem Solver. So what does this tell us? There are gaps in learning that need to be addressed. Many digital solutions have fallen short of building capacity effectively because users must adopt inflexible and time-intensive processes that their schedules of healthcare workers cannot accommodate. Skills that are required by healthcare workers for data use are not accommodated for, nor are they easily self-taught on the job using self-directed materials. Basically, because healthcare workers are overburdened and have competing activities. And so the learning packages really try to accommodate that so that the healthcare workers can access content for their professional development at their own time and pace, which their schedules can accommodate for. Thank you so much for your time.
Hello everyone. My name is Danielson Onyango. I am a monitoring, learning and evaluation advisor with In-Supply Health. I shall take you through developmental evaluation in practice. In-Supply Health is a health advisory firm affiliated to JSI Research and Training Institute that provides customized guidance on supply chain management and design to clients. We seek to transform lives by co-creating innovative and sustainable solutions for healthy communities. We support our clients to develop supply chain maturity strategies, build organizational capacity supply chains, design and implement data-driven, optimized supply chain systems, as well as forecast health commodity needs. My presentation focuses on how we integrated developmental evaluation into SCALE project. SCALE stands for Supply Chain Alternatives for the Last Mile Equity, a project implemented in 4 northern counties in Kenya that are in the arid and semi-arid lands. The counties are Samburu, Turkana, Wajir, and Mandera. We have partnered with Amref Health Africa's Afya Timiza project and Save the Children International's Nomadic Health project to increase demand, improve service delivery, as well as strengthen supply chains for the provision of community-based services. It is important to highlight that the ASAL populations are generally marginalized, remote, hard to reach, and often migratory due to their nomadic lifestyle. The community health strategy, as defined by the National Ministry of Health, lacks specific focus on the challenges and realities of the ASAL counties. As you know, community-based services are a key component of reaching universal health coverage. In the ASAL counties, human resources are critical constraints. It is very challenging to recruit local trained health staff in these areas, and thus the workforce is coming from outside the community, which poses a number of cultural challenges, language barriers between communities and the health workforce, resulting in low motivation. In terms of community health volunteers, many fall below the literacy and numeracy requirements outlined in the community health strategy. Community health volunteers are also not very knowledgeable on supply chain management concepts, which poses a challenge during implementation. Currently, there is no guidance on how to adapt the community health strategy and supply chains for the ASAL region, but this is an area of scale to work on, supported by the DE results. Other cross-cutting challenges in these counties include insecurity, as two of the counties border insecurity-prone Somalia, as well as poor roads coupled with the poor communication networks. There are many other challenges that affect service delivery in these counties. Key to point out is the difficulty in accessing static resupply facilities by the community health volunteers due to long distances to the health facilities to clients that could be between 20 to 40 kilometers. You can imagine how challenging it would be for a community health volunteer to walk all this distance only to find that the facilities are stocked out with life-saving commodities that they really needed. We have classified these regions as generally complex environments with limited evidence that addresses their unique challenges in provision of community-based services. We thus adopted the developmental evaluation approach. DE is a utilization-focused approach that provides data in real time as much as possible to support a rigorous adaptive learning process to facilitate innovation in complex environments. A key feature of DE is the embedded approach, where the evaluation team actively helps shape the interventions, surfacing data and insights are given consideration during implementation with the purpose of identifying areas of adaptations with every new piece of information gotten. With the embeddedness of the evaluation team, evaluation becomes everyone's responsibility. As opposed to the traditional evaluation, which the design is based on a linear cause effect with generalizable outcomes, DE captures system dynamics, interdependencies, and emergent interconnections with outcomes that are context specific, and the methodology is flexible. DE results thus serve as a springboard to take action. At the beginning of the implementation, we identified base models that were being used to increase uptake of community health services. Thereafter, we rely on the routine data collection that takes place during implementation, as well as periodic intense data collection that takes place every 3 to 6 months, which we call waves of targeted inquiry. In each wave of targeted inquiry, we prioritize 3 to 4 learning questions that are developed jointly and are of high interest to the 3 projects. Data collection is highly qualitative, collecting information from women, community members, and health system personnel. We rapidly conduct analysis of data, and thereafter, through a joint sense-making process, which is a facilitated process looking at raw data and initial beams to generate insights on how projects need to adapt and adjust to fit the unique context. Each partner prioritizes areas of adaptation based on the DE outputs and go out to adjust their models. This process continues and aims to iterate on implementation approaches in real time by fostering deeper understanding of the information emerging. At the end of the project, it is expected that models identified will be tested over time, and we shall have final model or models. To this far, we have conducted 2 waves of targeted inquiries. In wave 1, we found out that there was low motivation for the community health volunteers to carry out their duties, including that of community-based distribution. Specifically, the community health volunteers remained undertrained as training topics are largely partner-driven, with mentoring and supervision structures to support them being either non-functional or non-existent. It was also noted that the community health volunteer roles have expanded, yet there are no sustainable ways of rewarding them that is congruent to the duties assigned. Lack of commodities remain to be the biggest barrier to community-based distributions. The nomadic nature of these communities and their culture compound their challenges. Based on the findings of Wave 1, the stakeholders agreed to prioritize a deeper dive into the community health volunteers' motivation for Wave 2. We used a mixed method approach that combined quantitative and qualitative methods. We deployed a structured questionnaire through the Open Data Kit, that is ODK, that helped the CHVs to rank the various incentive methodologies as well as triangulate with the sub-county and county ranking for feasibility. We also conducted key informant interviews as well as focus group discussions with the CHVs, CHARs, that is community health volunteers, who are the direct supervisors of the CHVs, and the county and sub-county health management teams. Preliminary findings showed that different motivation strategies identified cut across the different counties. The top motivation strategies identified to be currently used included supervision or mentoring and provision of forms of identification to the community health volunteers. Generally, community health volunteers are motivated by a combination of extrinsic factors such as the need to serve their communities and intrinsic factors that include direct compensation as well as training. It is important to highlight that the top 5 motivators were non-financial, such as witnessing of visible improvements in the health of community members, as well as successful referral of community members to the facilities. The top 5 monetary motivators were compared to the top 5 identified by the county and sub-county health management teams as feasible, 3 of which were similar, such as peer exchanges and supervision and mentoring. However, whereas the county and sub-county managers identified stipend as a top motivator, the CHVs identified it also as a possible motivator, but among the bottom 5. It was generally agreed that food assistance and preferential access to resources were on the bottom of motivators as considered not feasible by county and sub-county managers. Our next steps include use of DE findings by the National Ministry of Health to review the community health strategy to be more reflective of the ASAL counties and human resources needs, as well as identifying the key areas for possible policy change. The partners are also identifying and prioritizing key areas of adaptations and modifications based on Wave 2 results to increase motivation. DE is particularly relevant and effective approach to adapting supply chain solutions across contexts. Its agility lends itself to understanding how to build responsive and resilient supply chains that are geared for recovery in the context of COVID-19 and future pandemics. I would like to take this opportunity to thank In Supply team for putting efforts to improve the supply chain systems in the hard-to-reach areas. Special thanks to Bill and Belinda Gates Foundation for funding scale projects to test models to increase uptake of community health services, including that of family planning. We also thank the sponsors of this conference through their generous contributions. Thank you, and I welcome questions.